My name is Grant Calhoun, and this is my in-service project for CE1. I'll be doing an updated literature on vestibulotherapy, as well as discussing the diagnosis and treatment of a few conditions common with vestibulotherapy. So some common diagnoses that we see in vestibulotherapy is BPPV, vestibuloneuritis, vestibular hypofunction, Meniere's disease, and 3PD. Treatment for BPPV includes cannulate repositioning. Some examples include Epley maneuver, CE1, and the Brandt-Daroff, just to name a few. There's also been shown within the literature that BPPV is linked to a vitamin D deficiency. So patients who are experiencing repeated symptomology of BPPV might also be dealing with a vitamin D deficiency, something to consider with our patients. For diagnosis of the BPPV, the Dix-Hallpike maneuver is the best objective test for this. It should be done with the head rotated 45 degrees towards the affected side. It has been shown that anything past 90 degrees of rotation may give a false positive to the other side. This would be not ideal because we want to identify one side at a time for the BPPV so we can best treat it with the Epley or whichever cannula repositioning maneuver you prefer. The other thing that should be considered with diagnosis for BPPV is the symptomology. BPPV should be intense symptoms, whereas anything reported as mild should be, other conditions should be considered first, such as vestibuloneuritis. This is a condition where the nerve inside the inner ear is being pinched by inflammation and causing improper signals to the brain. It will mimic a lot of symptomology of BPPV, except for vestibuloneuritis will not have episodic symptoms, it'll be consistent. So everything might be similar, and patients may even report that they get dizzy with rapid head turns. However, the Dix-Hallpike and the Epley will not be effective because they're not repositioning the cannulus within the ear, it's the nerve itself that is causing issues. Treatment for this will be best to use to address deficiencies such as balance, endurance, muscular strength. These are things that we can find in the objective portion of the initial treatment and carry forward throughout the therapy session with the patient. Similarly, vestibulohypofunction is a condition associated with the nerve itself. There's not a lot of research associated with this condition. However, diagnosis will be mild to moderate symptoms not associated with positional changes. Once again, the best treatment is to find deficiencies and treat those, and the hypofunction will address itself. Meniere's disease is when there is endolymph built up within the inner ear. This causes pressure on that nerve and causes similar symptoms to BPPV, in which case there's intense vertigo, unstable balance, etc. This is often diagnosed by an audiologist or an ENT. However, oftentimes a physical therapist is the first doctor that a patient will be seeing. So it's important to be watching out for descriptions of fullness in the ear, rapid hearing loss, and symptoms associated with one side of the body. However, Meniere's disease could potentially be on both sides. It is much more rare. Meniere's disease can also be treated with medications, injections, and surgical considerations, as well as a diet change in order for the body to help clear that endolymph on its own. These are things to also consider as well as the vestibulotherapy that we will be providing. 3PD is a complicated disease because there's nothing wrong with the inner ear. Instead, it's with inside the brain, the parts that are communicating between dizziness and emotion are not talking to each other the way they're supposed to. Oftentimes, patients will report high anxiety, depression, cognitive decline. These are cues that something else internal might be going on that is causing their dizziness. 3PD also has symptoms that are constant every day, and they're usually mild. They're not associated with the room spinning. However, they might feel lightheadedness, wooziness, feel like they're not themselves. These are all conditions that are real to the patient. However, there's nothing inherent that we can treat as therapists. So oftentimes we can address the vestibulotherapy and find deficiencies such as strength, endurance, balance, etc. However, to give the patient the full treatment they deserve, we should refer out to speech therapy or a psychologist for further treatment to address what's going on within their brain. Finally, I created a quick guide for reference of intensity of symptoms as well as diagnosis associated with the conditions that I've talked about so far. This is good info to have during the subjective and objective portions of the initial eval for quick reference during treatment so that we can better address the patients and the needs that they have. I have also included all the references that I used to gather the information provided before. Thank you so much for listening, and I hope this was helpful.